Not every bloated, gassy, or upset stomach tells the same story. A patient with early satiety might have functional dyspepsia, while another with diarrhea could be malabsorption, and yet someone else suffers from IBS. Today, we're dissecting the subtle clinical distinctions that often stump exams and even junior doctors. Accurate differentiation between IBS, dyspepsia, and malabsorption is critical for targeted therapy, for avoiding unnecessary investigations, and for acing clinical exams. By the end of this video, you'll be able to identify key distinguishing features and understand the underlying mechanisms. Functional dyspepsia is a disorder of the upper gastrointestinal tract, mainly related to impaired gastric motility and visceral hypersensitivity. Patients typically present with epigastric pain or burning, early satiety, and postprandial fullness. Mechanistically, delayed gastric emptying and impaired fundic accommodation lead to inefficient digestion, which is why they feel discomfort even after small meals. Clinically, red flags like significant weight loss, vomiting, or GI bleeding are usually absent. High-yield insight. Dyspepsia symptoms improve with prokinetics or acid modulators. Unlike IBS or malabsorption, diarrhea is not a dominant feature. IBS, on the other hand, is a functional disorder of the lower gastrointestinal tract characterized by altered bowel habits, constipation, diarrhea, or mixed patterns, along with abdominal pain that is often relieved by defecation and associated bloating. The underlying mechanism involves visceral hypersensitivity and dysregulation of the gut-brain axis, causing abnormal motility and heightened pain perception. Red flags are absent in IBS as well, such as bleeding or significant weight loss. High-yield insight. The Rome IV criteria guide diagnosis. Recurrent abdominal pain at least 1 day per week over the past 3 months, associated with changes in stool frequency or form. If you're finding this differentiation clear and exam-ready, pause, save, and share this video. These distinctions are high yield for medical exams. Malabsorption syndromes are different. They result from a structural or functional inability of the small intestine to absorb nutrients, leading to chronic diarrhea, steatorrhea, fatty stools, weight loss, and micronutrient deficiencies. Mechanistically, this can arise from enzyme deficiencies, mucosal damage such as in celiac disease, or bile salt deficiency, all of which impair nutrient absorption. Clinically, lab findings often reveal anemia, hypoproteinemia, and vitamin deficiencies. High-yield insight. If a patient presents with chronic diarrhea plus nutritional deficiencies, always consider malabsorption before labeling them as having IBS. Now let's integrate and differentiate all three clearly. Functional dyspepsia primarily involves the upper GI tract. Its main symptoms are early satiety, postprandial fullness, and epigastric discomfort. Red flags are rare, and the underlying problem is motility-focused. IBS is a lower GI tract disorder. Its hallmark is abdominal pain associated with altered bowel habits, diarrhea, constipation, or mixed. Bloating is common, red flags are absent, and the disorder is driven by gut-brain axis dysregulation. Malabsorption affects the small intestine, and its main presentation is chronic diarrhea, weight loss, and nutritional deficiencies. Red flags are often present, and the mechanism involves structural or enzymatic problems impairing nutrient absorption. High-yield insight. Symptoms may overlap, but paying attention to bowel habits, nutritional status, and red flags helps you distinguish these clinically. To summarize, dyspepsia points to upper GI motility problems with early satiety. IBS indicates functional lower GI issues driven by bowel pattern changes and gut-brain axis dysregulation, and malabsorption signals structural or enzymatic defects causing diarrhea plus nutrient deficiencies. For exams or clinical practice, these distinctions can be the difference between a correct diagnosis and a missed case. If you haven't watched my previous video on low gastric acid, why protein digestion fails, go check it. It ties perfectly into malabsorption mechanisms. And in the next video, I'll cover red flag GI symptoms every med student must spot, essential for exams and clinical rotations. Follow now so you don't miss it.